Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're talking about spinal cord injuries. We will start the way we always do, of course, with a practice question to get your brain warmed up. So a client is brought into the ED after diving into a shallow water and striking his head. He cannot move his legs. He reports tingling in his hands, has a BP of 82/50, heart rate is 48, warm, dry skin, respirators are 24. What action should the nurse take first? We have A, rapidly infuse IV fluids to correct hypotension. B, apply external warming devices to prevent heat loss. C, maintain spinal immobilization and prepare for airway support. Or D, place the client flat with legs elevated to improve blood pressure. Okay, tuck that away, save it for the end. We will circle back, but first, let's talk about the A and P behind what's going on with a spinal cord injury, or you might say it abbreviated SCI. First, picture the spinal cord as the main, I'm going to go with like a fiber optic cable running between your brain and the rest of your body. Every voluntary movement, touch, sensation, oh my gosh, that's hot, move my hand, those automatic things like keeping the blood pressure up, the heart beating, the gut moving. These are all signals traveling through that one cable. And it runs from the brainstem down to about L1, L2 vertebrae. That's your lumbar vertebrae. And it's protected inside that vertebral column. And from it, a branch, the spinal nerves that exit at each vertebral level. So every vertebrae, we've got a little exit from that one big fiber optic cable. Now, if you slice that cord in a cross section, you see gray matter in the middle, shaped kind of like a butterfly, where cell bodies live, and white matter all around it. That is made of myelinated tracts that are carrying signals up and down. The ascending tracts going up are your sensory highways. They bring info like, touch, pain, temp, proprioception up to the brain. Then the descending tracts are your motor highways that send commands from your brain down to your muscles. Pull your hand away from that hot stove. Now, location really matters with spinal cord anatomy. Cervical levels up in your neck tend to control arms, diaphragm. Thoracic down here controls the intercostals and trunk, and then lumbar and sacral levels are down below, so legs, bowel, bladder, sexual function. The classic one to engrave into your brain is C3, 4, and 5, keep the diaphragm alive. The phrenic nerve that makes the diaphragm contract originates in that C3, 4, 5 area. So injuries at or above C5 are a huge red flag for respiratory compromise. The cord is also home to a lot of our autonomic wiring. Sympathetic outflow lives between T1 and L2, and that's your fight or flight system that maintains vascular tone and heart rate. Obviously, very important. Parasympathetic control comes largely from the brain stem via the vagus nerve and from the sacral cord, which is S2 to S4. So when the spinal cord is injured, we are not just losing movement and sensation, we can actually lose the connection between the brain and the sympathetic system, leading to a loss of vascular tone and that classic combo of hypotension and bradycardia that hint, you did see in our practice question. Okay, so that's kind of where things live, that one fiber optic cable carrying things up on your ascending tracks and down on your descending tracks. Now let's move into what looks like when something goes wrong, when a spinal cord injury actually happens. We get damage to that fiber optic cable. Okay, there's two big phases. We get a primary and then a secondary injury. The primary injury is the actual mechanical event. Compression, contusion, laceration, or, gosh forbid, a complete transection cutting all the way across that cable from a trauma. Now, that could be something like a displaced vertebrae, bone fragments, or bleeding into the spinal cord. But the really sneaky part is that secondary injury. After the initial trauma, there is a whole cascade that goes on. Inflammation, edema, ischemia, excitatory neurotransmitters, and free radicals all start damaging tissue that was not initially destroyed. And that edema inside the closed canal increases pressure, which is going to further cut off blood flow and oxygen to the cord. So first we get trauma, and then that whole inflammatory cascade makes it way worse. Basically, injuries worsen over hours if we don't stabilize it. There are two terms I want to pull out here just because they get tested a lot, and in my opinion, they're easy to mix up. Spinal shock and neurogenic shock. Spinal shock is local to the cord. Think of it as the cord going into like stunned mode below the injury. We lose our reflexes, our muscles go flaccid, there's no movement or sensation, and over days to weeks, those things may return, spasticity can develop, and we can kind of better determine the true extent of what permanent damage looks like. Neurogenic shock, on the other hand, this is one of our types of distributive shocks. It causes hemodynamic problems that happen when sympathetic outflow goes kaput. Basically, vessels lose their tone and they get really big. Our heart loses the sympathetic drive and slows down, but the parasympathetic is still doing its thing. So we get really vasodilated. That causes massive hypotension. Our heart rate plummets, bradycardia. But we're really warm. It's not that cold shock where we're clammy. Those vessels are really dilated and big. So you're actually quite warm. You might even be kind of flushed or pink, but your blood pressure is getting really low and the heart rate is not coming up to compensate. So again, kind of think back to that practice question. You might see what's going on under the surface there. Okay, let's bring all this to life with a clinical scenario and walk through what you would actually do as the nurse and why. So let's say you are working in the emergency department. You're going to get a call in from EMS. You've got a 24-year-old male, suspected diving injury, pulled from a backyard pool after hitting his head on the bottom of that pool. Now, he never lost consciousness, but he did report immediate loss of movement in his legs and feels like his arms are kind of weak. So he gets in. First thing we're going to do as the nurse is get him on a backboard with a cervical collar in place. Now, EMS is really awesome. I would be shocked if they didn't already have this in place, but you really want to make sure that it is because we don't want any movement in that C-spine, that cervical spine. That's going to really be one of your first priority actions. So let's go through those priorities. We know our ABCs. We're going to have kind of a side of C-spine going on here with this scenario. So A, airway open. He's talking in full sentences. He might be a little breathless. He's scared. He's panicked. But usually airway is open. And that's what we see in our client here. Now with B for breathing, really watch that chest rise and fall. You might notice that most of the movement is in the upper chest and shoulders and not down below in the belly, which is a clue that their diaphragm and intercostals could be affected. Remember, C345, keep the diaphragm alive. All right, let's grab your vitals. Here on this client, we've got a BP of 82/50, heart rate of 48, respiratory at 24, and an SpO2 at 93. His skin is warm, dry, and pink. So that's your kind of basic ABC. You've stabilized the C-spine, first assessment. Let's kind of loop it back to the patho. What do we think is going on here? Well, we see a low blood pressure and a low heart rate, but his skin is really warm. All that put together really screams neurogenic shock to me. It's not like, hypovolemic shock where we lose a bunch of fluid and our heart rate cranks it up to keep our pressure going. Basically, for him, his sympathetic system is offline. Vessels are dilated, blood is pooling, cardiac output is dropping. But because that sympathetic output is gone, we cannot speed up the heart rate. So that bradycardia is super, super scary. So all that being said, what do you need to do? Maintain that strict spinal alignment. No twisting, no flexing. We are going to make sure we are in C spine precautions. And one thing that means for you as the nurse is if you are going to roll him, you need to do a full log roll. That takes at least 3 people, and one person is dedicated to holding the head in neutral alignment. And that person is in charge. So they do the countdown. Okay, we're going to roll right on my count. 1, 2, 3, roll. Because they are keeping that head in neutral alignment. Basically, remember, again, back to patho here, we've got this big fiber optic cable. It is fragile, it is injured, and our job is not to do any more damage. We don't want to kink, stretch, or pinch that any more than it already is, which is why we're in C-spine. And if we do move, we're going to do the log roll. 3 people, person at the head of the bed maintains the neck in neutral alignment. That is a super important nursing intervention. Okay, so what actions are we taking next? We've done our assessment, our ABCs, we've C-spined. The provider's probably going to be preparing to get some imaging quite quickly so that we can figure out exactly what we're dealing with. And it is really important to make sure that we have intubation equipment at the bedside. If that diaphragm gives out, we need to be able to move quickly on keeping that airway patent. Airway is a big priority here. In your neuro assessment, make sure that you are documenting the motor and sensory level as an important baseline for kind of where is the injury at now. So let's go through how this would look like on our client. We're going to start higher up with the shoulders. I usually say, hey, shrug your shoulders for me. He can do this fine. Bend your elbows. That was kind of weak, but he could do it. Then go down to the hands, test their grip strength. Say, hey, hold my hand, shake my hand, give my hand a squeeze. And for your client here, this is weak, and he says it's kind of tingling. His finger wiggle, minimal, not really good. So now keep moving down. Can he wiggle down to his toes? No. Where sensation stops is where you want to document. So, can you feel this? Can you move this? Sensation and motor. So for this client today, we're going to say it stops around about at the nipple line here, and we document that at T4. Why is that an important baseline? Remember, we have our primary and our secondary injury. It can get worse as we have that inflammatory cascade, as we get edema, and there is more pressure on the cord. And at T4, we're pretty high up. Remember, up in the cervical region is where we have a innervation of the diaphragm. So if it continues to get worse, we very much could need airway support. So that's kind of how you're going to assess neuro-wise in these clients. Start at the top, work down, document motor and sensation, and kind of where that cutoff point is. Now, next priority intervention, we've kind of looked at airway, breathing. Circulation is not so hot in this client either. I'm kind of worried about neurogenic shock with that low BP, that bradycardia, and him being really flushed and warm. So how are we going to get that blood pressure up to increase perfusion? Well, the problem is that our blood vessels are really dilated, and we don't have the sympathetic input to increase our heart rate. So we're going to focus on a vasopressor infusion. Dumping in a bunch of fluid, not going to help. The problem is not lack of volume, it's lack of vascular tone. Too much fluid can worsen the problem. We want a vasopressor. Usually it's norepinephrine or norepi in this situation that is going to tighten those dilated vessels. Norepi really works on those alpha receptors that cause vasoconstriction. Our blood vessels are too big, let's make them smaller. That's what norepi does. It's going to get our pressure up, which is critical to perfusing that injured cord and preventing further secondary damage. One more intervention that I want to make sure is on your radar is potentially going ahead and placing a Foley catheter. This is great for monitoring urine output, but really primarily in a spinal cord injury above T6, we want to prevent bladder distension, reduce the chance of autonomic dysreflexia. Basically, everything above T6, if we've got an injury up there, the bladder loses voluntary control and it can become spastic. So, very common to see urinary retention, and that distension from urinary retention can trigger that complication of autonomic dysreflexia. So, it's not the number one priority right now. We're dealing with shock, we've got a circulatory issue. By all means, get that norepi started first, get this stabilized, but you may be asked once they're stable to go ahead and throw that fully in. It's going to help track perfusion with that urine output anyway, but also prevent that complication of autonomic dysreflexia further down as well. Okay, so we're in C-spine precautions. We have got intubation equipment at the bedside. We are still breathing, although it's kind of mostly in our upper chest, so we're keeping a close eye on that. We are addressing circulation with our vasopressor. It is time to get this client transferred to the ICU. The first thing they'll be doing in the ICU is continuing to titrate that vasopressor to keep our blood pressure in a normal range. As this injury settles and we kind of see what the permanent level of damage is, it is really important that we keep that spinal cord perfused. That is going to prevent worsening trauma. But other than that, we are really letting the spinal cord rest, letting it heal, and continuing to assess to see what the level of damage is going to look like long term. So our nursing interventions are less focused on fixing this problem, because we can't magically fix a spinal cord injury, and more focused on preventing complications. A lot of those complications come from immobility. So we need really good skin care. We've got to turn and reposition every 2 hours. And remember, you're using a log roll and maintaining C-spine precautions. We need DVT prophylaxis because they can't get up. Very careful positioning with splints, pillows, all sorts of things like that. We are going to do really frequent respiratory assessments and do good chest PT and try to kind of keep things moving as much as possible. And as the swelling starts to go down, they can start to see a little bit of movement and sensation return. So with this client, reflexes started to return to the legs. He did not regain voluntary movement, and spasticity began to appear. This is kind of when the cord is transitioning out of that spinal shock and showing us really what the full extent of the injury is. So for our client here, eventually his injury is classified as a lesion in T4, which means he did retain diaphragm function because it was below that cervical C3, 4, 5. But he needed assisted devices, PT, OT, a lot of different therapy and assistance, especially for lower body care. For most of our clients experiencing a spinal cord injury like this, after the ICU, we are going to transition them over to a rehab stay where they can really get all of that intensive therapy and learn about maximizing function and preventing complications. Those complications, I've kind of got two different things to point out. We've got the acute complication of autonomic dysreflexia that we mentioned. Gotta watch out for that. But more commonly, the complications of immobility, like skin breakdown and contractures from positioning. So we're really going to focus on preventing those with our PT, our OT, all of our great therapy during that rehab stay. Okay, I think you have all the pieces now to circle back to our practice question, and hopefully now you can get to the right answer and understand why. So we have a client brought into the ED after diving into shallow water and striking his head. He can't move his legs, reports tingling in his hands, and has a BP of 82/50. Heart rate is 48, respirators are 24, and he does have warm, dry skin. What action should the nurse take first? We have rapidly infuse IV fluids to correct hypotension. B, apply external warming devices to prevent heat loss. C, maintain spinal immobilization and prepare for airway support. Or D, place the client flat with their legs elevated to improve blood pressure. Think it through. What did we do in our scenario? This practice question is totally about our clinical scenario today. What was our priority? He dove into shallow water. We suspect a spinal cord injury. The priority is C, maintain spinal immobilization and prepare for airway support. This client has signs of a high spinal cord injury, and I think they look a little shocky, like they might have neurogenic shock. They had trauma, paralysis, and now they have hypotension and bradycardia with warm, dry skin. So I think their vessels are dilated, their sympathetic system cannot kick in to get that heart rate up, and blood is just pooling, causing that warm, dry skin instead of perfusing our vital organs. So the first priority is to prevent any further damage to that spinal cord, that fiber optic cable sending all of our signals. We've got to immobilize, backboard, C-collar. Anytime we move, we do a log roll. And then we need to be ready to support breathing, airway support, ABC, because we know cervical injuries can quickly compromise the diaphragm and respiratory muscles. So quickly looking at our other answers, A, rapidly infusing IV fluids. This is not a good idea in neurogenic shock. It is not a fluid problem. It is a vascular tone problem. If we pour a bunch more fluid in there, our vessels are still going to be super dilated and we're not going to get the pressure up. This can actually worsen the problem. B was apply external warming devices. Also not an appropriate action. This client is already warm. They're vasodilated. They are not cold or hypothermic. Don't do this. And lastly, D, putting them flat and elevating their legs might kind of like transiently maybe fix the BP, but it breaks our number one rule of immobilizing the spine. This is an unstable spine. If I go and kick their feet up, I could worsen the spinal cord injury. So don't do this either. The only correct action was immobilize that spine, and that is your priority. That's really your key takeaway that I want you leaving this episode with. Your first job is protect that cord and protect that airway. Everything else comes after. If you can recognize the combo of trauma, new paralysis, and then hypotension with bradycardia as neurogenic shock, you will know what to do. You will jump into action and know that immobilizing and being prepared for airway support are your priority moves. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.